Starting with epilepsy, definition of epilepsy. First, we'll see the definition of seizures, and then we'll see the definition of epilepsy. What is a seizure? Seizure is a transient occurrence of signs and symptoms, basically paroxysmal events due to abnormal excessive hypersynchronous neuronal activity in brain. So because of any cause that we'll be seeing further, there is this hypersynchronous, means it is very hyperexcitable, the action potential is very high, so such type of excessive hypersynchronous neuronal activity in brain. So because of this hypersynchronous neuronal activity in the brain, there is a transient occurrence of signs and symptoms. That is, there is a transient occurrence of a paroxysmal event which is known as seizures. The seizures basically occurs because of abnormal excessive hypersynchronous neuronal activity in brain. Okay, so this was about seizure. What do you understand by epilepsy? So epilepsy is basically a chronic neurological disorder, okay, which is characterized by occurrence of two or more unprovoked seizures at least 24 hours apart. We understood what is seizures. So when there is two or more unprovoked seizures which are at least 24 hours apart, or a single unprovoked seizure in an individual with an underlying condition that increases the risk of subsequent seizures or presence of an epilepsy syndrome. Okay, so basically epilepsy is a chronic neurological disorder which is characterized by when there are two or more unprovoked seizure within 24 hours, or if there is associated epilepsy syndrome, or there is a single seizure which is unprovoked in an individual with an underlying condition that increases the risk of subsequent seizure. Okay, so there are some pointers that we need to understand. Pehla, the chronic neurological disorder. Second, characterized by occurrence of two or more seizure within 24 hours. या फिर a single unprovoked seizure in an individual with an underlying condition that increases the risk of seizure या epilepsy syndrome. This was about seizure. Seizure was because of excessive hypersynchronous neuronal activity, while epilepsy was a chronic neurological syndrome because characterized by occurrence of seizures two or more within 24 hours. Now, so this way we understood what is a seizure, what is epilepsy. Now we'll classify. So there's this International League Against Epilepsy 2017 classification. Here the seizure is divided into focal onset. Focal onset means they originate from a network limited to one cerebral, to a particular cerebral hemisphere, okay, like to a particular area, that is focal. While generalized is basically like it is spread across a particular cerebral across the cerebral hemisphere. Like it can be cellular, biochemical, structural abnormality, it can be anything. So that is generalized. So let us talk about focal first. So seizures are divided into focal, generalized and unknown onset. Focal onset is further divided into focal onset seizure with loss of consciousness and without loss of consciousness. When there is loss of consciousness, that was previously known as complex partial seizures, and without loss of consciousness were previously known as simple partial seizures. This together have different manifestations like motor or non-motor. In motor onset, we have atonic seizures, atonic, clonic, epileptic spasm, hyperkinetic, myoclonic, tonic. So atonic, tonic, epileptic spasm, hyperkinetic, myoclonic. Non-motor onset includes behavioral arrest, cognitive, emotional, sensory and autonomic. Okay, so this was motor, non-motor. Well, generalized onset is always associated with loss of consciousness. Generalized onset can be absent seizures. Absent seizures are typical, atypical, myoclonic या फिर eyelid myoclonia. So atypical, myoclonic या eyelid myoclonia. While motor form of generalized onset seizures can be generalized tonic-clonic seizures, only clonic, myoclonic, tonic-clonic, myoclonic, atonic or epileptic spasm. So basically the main important one is generalized tonic-clonic. Then there's this unknown onset which can be motor or non-motor. In motor we can have epileptic spasm, and non-motor there's this behavioral arrest. Okay, so this was the classification, that is seizure, focal onset with loss of consciousness, without loss of consciousness. Generalized onset can be absent seizure, motor seizures, and unknown onset. So there's this new classification of seizure which is similar. There's this focal onset which includes motor, sensory, autonomic, cognitive features. Well, there's this generalized seizures which includes absence, tonic-clonic, myoclonic, tonic and atonic. Okay, and other can be focal, generalized or anywhere. Okay, unknown. That is epileptic spasm. Now let's talk about focal seizure in detail. So focal seizures are basically seizures that arise from a neuronal network limited to a particular part of cerebral hemisphere. That's why it is focal. Now we'll talk about focal seizures without discognitive features. Focal seizures without discognitive features, that is without loss of consciousness, right? So basically can cause motor, sensory, autonomic or psychic symptom, ठीक है, without impairment of. So there's no impairment of consciousness, but there can be motor, sensory, autonomic symptoms. So let us talk about focal motor seizures. So basically they arise, suppose it is arising from a right primary cortex at the area which is controlling the hand movement, that homunculus, right, motor homunculus. So in that area it is controlling the hand movement in a right primary cortex. So when there is a seizure, when there is hypersynchronous activity, the contralateral involuntary movement will occur. So the patient will do this type of hand movement, right? And typically clonic type, take a flexion extension, clonic type 2 to 3 hertz measure, take a, along with the abnormal face movements, because both are related. Abnormal face movement because it is synchronous with hand. So this was focal motor seizures which arise from the, suppose it arises from the right primary cortex at the area which has the hand movements. So there would be contralateral involuntary movement which will be typically clonic with 2 to 3 hertz of frequency. What are the features of focal seizures? There are 3 important features of focal seizures, which includes Jacksonian march, Todd's paralysis, and epileptica paritalis continua. So now we talk about the Jacksonian march. So Jacksonian march is an abnormal motor movement begin in every restricted region, in a very restricted region. So basically what happens is there's this abnormal movement which begins in a very, say one particular restricted region. Suppose it starts with finger. Okay, so this abnormal movement then will gradually progress in seconds or minutes to the larger portion. Like it will start distally and spread complete proximally. Samjha? Spread of the seizure activity over a progressively large region of motor cortex. This is what is known as Jacksonian march. What is Todd's paralysis? It is basically there is this local paresis or paralysis regions minutes to many hours following seizures. The following seizures, that is local paresis or paralysis. Now epilepsy partialis continua. What is this? Seizure continues for hours and days. So it is refractory to medical therapy. Now the other manifestations of focal seizures with loss of consciousness are, it can be visual manifestations like flashing lights, hallucinations, then vertigo, unusual sensation of intense order, epigastric sensations. So these are other manifestations which includes, so what we saw was focal seizures can manifest as motor. So we saw what motor was. Okay, then there could be sensory, autonomic or psychic symptoms. So in sensory there could be paresthesia, then there could be flashing of lights, hallucinations, unusual intense order, vertigo. Okay, so always remember, focal seizure is not related to an epilepsy syndrome. It's always a medical cause. There might be some lesion in that particular area which is leading to a focal seizure. Okay, EEG is always normal in post-ictal phase. There is no role of anti-epileptic drug, because what we have to do is we have to treat the underlying lesion. Okay, so this was about focal seizures without any loss of consciousness, that is without discognitive features. Now focal seizures with discognitive features. So here it is associated with impairment of patient's ability to maintain a normal contact with environment. So basically there is loss of consciousness. So what happens, there's this 3 phases of a focal seizure with discognitive features. So it starts with an aura. So it is only seen in focal seizures with impaired awareness. So there are these subjective symptoms of aura, which includes like most common is GIT symptom. Patient perceives that all the foods and all the organs would be coming out from his mouth. Okay, then there is visual aura, that is he perceives things which are not present. Or psychic aura, like it's deja vu. So this is aura. Then we have this ictal phase, that is the seizure. There's sudden behavioral motionless stare. The patient will stare, sudden behavioral motionless stare, it marks the onset of impaired awareness. Okay, this happens for some time. And then there's automatism. What is automatism? Automatism is basically involuntary autonomic behavior with wide range of manifestations. What happens is, after this motionless state, the patient will start doing actions like chewing, lip smacking, swallowing, picking movements of hands. So, and then there would be anterograde amnesia. So it starts with an aura, which could be anything like GIT aura or visual or psychic. Then it starts with an ictal phase, which is characterized by motionless stare. And then automatism, which is basically chewing, lip smacking. There is involuntary automatic behaviors. Okay. Now, after this, the patient is confused. Transition to full recovery of consciousness may range from seconds to hours. So, mostly, this type of seizures with dyscognitive feature, it is always associated with some epileptic form syndrome. There is no as such identifiable cause. Okay? What is the most common pathology is hippocampal sclerosis, that is medial temporal lobe epilepsy. So here we require anti-epileptic drug and EEG shows temporal spikes. So this was about focal seizures with dyscognitive features. So we completed the focal seizures. Now we'll talk about generalized seizures. So generalized seizures, basically it arises from some point and then it immediately and rapidly spreads to neuronal networks of both the cerebral hemispheres. So it's this generalized seizures. It is always associated with loss of consciousness. Okay. Now generalized seizures can be absent seizures or atonic seizures, myoclonic seizures, or generalized tonic-clonic seizures. Okay. So, what are absent seizures? Absent seizures can be typical absent seizures or atypical absent seizures. Typical absent seizures, sudden within seconds, with brief lapse of consciousness without loss of motion. There would be choto sa loss of consciousness, okay, very little, for few seconds, okay, and there's no postural abnormality like loss of postural control. It is accompanied by subtle bilateral motor signs like rapid blinking, chewing movement, or small amplitude clonic movement. So after a brief lapse of consciousness, without loss of postural control, there would be some subtle bilateral motor signs like rapid blinking, chewing, small amplitude clonic movements. So it is always a part of epilepsy syndrome. Okay. So basically it is genetically determined epilepsy. Okay. Now onset is usually in childhood, 4 to 8 years, or early adolescence. Okay. First clue would be the teacher might notice that in school the child is daydreaming a lot. There is decrease in school performance. Okay. The EEG would show generalized symmetrical 3 Hz spike and wave discharge that begins and ends suddenly. So as you know, there is a sudden brief lapse. So on EEG there would be 3 Hz generalized spike and wave pattern and then there will be normal EEG background. Okay. Now if we have to see this, there's this, you can hyperventilate the child in order to provoke this seizure. It remits by 12 years. There is no need of lifelong therapy. Okay, so typical absent seizures was sudden onset of brief lapse of consciousness without loss of postural control. After that, we have this bilateral motor signs like rapid blinking, chewing, small amplitude clonic movement. Part of epilepsy syndrome. Onset is usually in childhood or in early adolescence. First clue would be daydreaming and decline in school performance. EEG would show generalized symmetrical 3 Hz spike and wave discharge that begins and ends suddenly on a normal EEG background. Okay, and it remits by 12 years. Now we have this atypical absence seizure. Here there's loss of consciousness of long duration. See? There it was a brief lapse of consciousness. Here it is of long duration and less abrupt time. It is also associated with motor signs as loss of postural control. Okay, so what does EEG show? EEG shows generalized slow spike and wave pattern. So it is associated with diffuse and multifocal abnormality of brain accompanied by mental retardation. So it is less responsive to anticonvulsant. That is atypical absence seizure. So now, we have completed the absence seizures in generalized one. Now we'll come to generalized tonic-clonic seizure. So what is this generalized tonic-clonic seizure? This is the seizure we see very commonly. So it begins with, abruptly begins without any warning. Well, some people may say they have this pre-monitoring symptoms, but usually it is not present and it is basically abrupt onset without any warning. So what happens, it starts with a tonic contraction of muscle. Tonic contraction, like sustained contraction, okay, of muscles throughout the body. So tonic contraction of muscles of expiration, larynx, that will lead to a moan or a nictal cry. Then there's this respiration impairment, secretions from the oropharynx and cyanosis. Contraction of jaw muscles can lead to biting of the tongue. And there's this sympathetic tone enhancement, which leads to increased heart rate, increased BP, and pupillary dilation. So this tonic contraction phase will last for 10 to 20 seconds, where there's this sustained contraction of muscles of expiration, larynx, impaired respiration, the secretion from the oropharynx, cyanosis, along with contraction of jaw muscle leading to tongue bite. So this was last 10 to 20 seconds, right? So there is this generalized tonic. The tonic while is done, now there will be clonic phase. Clonic phase is basically tonic phase with superimposed muscle relaxation. There is contraction relaxation, okay? So superimposition of period of muscle relaxation on a tonic muscle contraction. So period of relaxation will increase gradually till the end of the ictal phase. Okay. So this lasts for around 1 minute. Then there's this post-ictal phase. In post-ictal phase, the patient might be unresponsive. There will be muscular flaccidity, excessive salivation, bladder bowel incontinence, and confusion. Okay. So this is how it is. There's this tonic phase, clonic phase, post-ictal phase. What do you see in the EEG? In EEG, in tonic phase, we see progressive increase in generalized low voltage fast activity, which then further progresses to generalized high amplitude discharge. In clonic phase, we have spike and wave pattern. Okay. Now, other variants of generalized tonic-clonic seizures would be pure tonic or pure clonic. Okay. Now we have atonic seizures and myoclonic seizures. What is atonic seizures? Atonic seizures would be atonia. So, sudden loss of postural tone which lasts for 1 to 2 seconds. There's no post-ictal confusion, like suppose there's quick head drop and then collapse. Okay. So this is atonic seizures, like sudden loss of postural muscle tone. Myoclonic seizure is basically sudden and brief muscle contraction, shock-like, okay, associated with metabolic disorder, degenerative CNS conditions, or anoxic brain injury. Predominant feature in juvenile myoclonic epilepsy. Here also we have spike and wave discharge. Okay, so we saw different kinds of types of epilepsy. We saw absence, generalized tonic-clonic, atonic, myoclonic, and focal. Okay. Now we'll see what are the causes of seizures in epilepsy. So basically we have to remember 3 things. Okay, a normal brain is capable of having seizure under certain circumstances, and their difference in individual is susceptibility or threshold of seizures. Okay, there are differences. So basically there are some endogenous factors. So normal brain is also capable of having seizure. Second thing we have to remember is variety of conditions have likelihood of resulting in chronic seizures. Okay, it could be a penetrating head trauma. So all these are known as epileptogenic factors. And third, there's always some precipitating factors to seizures. Okay, so 3 things, that there might be endogenous factors, epileptogenic factors, and precipitating factors. Okay, now we'll see about the causes of epilepsy seizures in age-wise. So suppose a neonate, it can be hypoxia, increased intracranial hemorrhage, CNS infections, metabolic disturbances. While in infants to children, like less than 12 years, it could be febrile seizures, genetic disorders, CNS infection, developmental disorders, or trauma. In adolescents from 12 to 18 years, again, CNS infection, genetic disorders, brain tumor, drugs. In young adult, we have trauma, brain tumor, drugs, alcohol withdrawal. While in more than 35 years, that is in adults, we have cerebrovascular disease like stroke, brain tumor, infections, alcohol withdrawal, Alzheimer's, and metabolic disorders like uremia, hepatic failure, electrolyte disturbances. There's this decreased hypoglycemia or hyperglycemia. All this can lead to seizures. Now, certain drugs like theophylline, imipenem, quinolones, then lithium, tricyclic antidepressants, barbiturates, all leads to epilepsy. Now, what is the pathogenesis? The pathogenesis, we have to remember the 3 factors. That is the precipitating factor, endogenous factors, and epileptogenic factor. Precipitating factors are, suppose, sleep deprivation, fever, alcohol withdrawal, hypoxia. All these are precipitating factors. Endogenous factors, factors because of which the brain has lowered this threshold for seizures. It could be because of genetic syndromes, it could be because of mutations, or there's this family history, developmental disorders. These are the endogenous factors because of which brain is susceptible to having seizures. Then we have epileptogenic factors. These factors which have more chances of developing seizures, like trauma, CNS infection, CVD, tumor, anything. So all this will lead to epileptogenesis. Okay, so precipitating factors, endogenous factors, and epileptogenic factors will lead to epileptogenesis. What is epileptogenesis? Transformation of normal neuronal cortex into hyperexcitable one. We know that basically seizure is hypersynchronous activity. So because of all these factors, in brain there is epileptogenesis. That is, the normal neuronal network gets transformed into hyperexcitable. This occurs in months to years after a particular epileptogenic factor. Injury initiates the process of decreasing the threshold basically. So there's this damage to brain and alteration in neuronal circuit. So how does this damage to brain and alteration in neuronal circuit occurs? It has two mechanisms. First, intrinsic mechanism to the neuron, and second is extrinsic mechanism. Intrinsic means there could be ion channel and receptor dysfunction, leading to imbalance in ion channel conduction or altered neurogenesis. In extrinsic neurons, we have neurotransmitter imbalance. There's increase in glutamate, decrease in GABA, decrease in serotonin. All this will lead to increased hyperexcitability. So there's this influx of extracellular calcium leading to opening of voltage sensitive Na plus channel, influx of Na plus, then repetitive action potential generation leading to hyperexcitability, high frequency burst of action potential, and hypersynchronization. As we saw in the definition, it was hypersynchronous factors. Because of this increased Na plus, increased action potential firing, there is high frequency burst of action potential and hypersynchronization. So what is this? This is the seizure in initiation phase. Now there would be recruitment of surrounding neurons leading to accumulation of calcium, deposition of NMD and extracellular calcium. Because of this, there will be increase in surrounding neuron and there would be propagation of seizure. So this is how the pathogenesis of seizure is. Okay. Now, how do you approach a patient with seizure? So, if there is an adult patient with a seizure, what you do is First, history. Ask about risk factors, predisposing event, anything. Then do the physical examination. Look at the signs of any kind of infection, systemic illness, organomegaly, head trauma, signs of cerebrovascular disease. Exclude the syncope, TIA, migraine, etc. Okay. So after you have done this, there can be two types of patient. One patient having a history of epilepsy treated with anti-epileptic drug. So assess the adequacy of anti-epileptic drug and side effects. So you do the CBC, electrolyte, serum glucose, everything. If everything comes out normal, then maybe the cause of epilepsy is because of subtherapeutic anti-epileptic drug. So change the drug accordingly. So if suppose it is abnormal, then identify the cause and treat it. Okay. If suppose the therapeutic anti-epileptic levels are also present, then increase it to the maximum dose. If suppose the patient has no history of epilepsy, then we have to rule out the metabolic cause of seizure. For that, we will be doing the laboratory studies. If suppose there is this positive metabolic screening, then do the further workup, like do lumbar puncture for infections, meningitis, culture, CT, MRI, okay, and treat the underlying cause. Or suppose if there is negative metabolic screening, do MRI and EEG. MRI to rule out any kind of structural abnormality, and EEG in epileptic form activity, 24-hour monitoring to classify the seizure disorders. Now, through this, we'll know the focal features of seizures or focal abnormalities on clinical lab and other evidence of neurological dysfunction. If all these things are there, then consider there might be any mass lesion or CNS infection or trauma and treat the underlying cause, and after that consider the anti-epileptic therapy. If there is no such reason, then it could be idiopathic seizures, then start with anti-epileptic therapy. Okay.